Okay, so we are on time. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Welcome everybody to this session in the Cornea series on Sinjab Academy to the Wonderland. And we are delighted to have Professor Christopher Liu from the UK, Professor Muhammad Bahgat from Egypt, and Mr. Ahmed Shalabi Bardan from the UK as well. To teach us about the topic which is related to the DALK. No need to introduce them because they are very well known and they are renowned speakers. And thank you very much, Professor Liu, Professor Bahgat, Mr. Shalabi, for accepting the invitation and for teaching us. So I will leave the stage to Professor Liu to moderate the session and at the same time to start with his presentation. Professor Liu, the microphone is for you.
Thank you. Can everybody hear me?
Yes.
Yes.
Thank you. So this session is about surgical planes and a little bit about suturing in DALK. There is a lot of misunderstanding for a lot of people, not everybody, about the surgical planes. And so I have assembled some experts to demystify this. I just want to open the session with 3 slides. So I'm going to talk about surgical planes and suturing. My name is Christopher Liu, and I work in Brighton and the Scottish Highlands. And here's my impression of bubbles. So the rationale for DALK is well rehearsed, and it is about preservation of healthy host endothelium. And this is particularly important in the young, as the endothelium would need to last a long. And also, if your donor material is not of very good quality, then the endothelium may not last very long either. Now, if you are preserving the host endothelium, then it eliminates the risk of endothelial rejection, and it will decrease the use of steroid eye drops, which is one of the reasons for an incidence of glaucoma following penetrating keratoplasty. Now, earlier removal of sutures, perhaps, well, certainly in children, but it is controversial in grown-ups. If the sutures are removed too early, there may be increased astigmatism. Certainly, there will be an increased strength of the globe with DALK compared with PK to sustain minor globe injury, especially for less deep DALK. So I will explore this concept with you in that we go as deep as we need to. A larger diameter graft is possible with DALK compared with PK, with no increased risk or very little increased risk of glaucoma or endothelial rejection. And generally speaking, there is better corneal shape with less astigmatism with DALK compared with penetrating keratoplasty. So where are these surgical planes? Well, if we look at this paper from Harminder 2013, we have the tear film, then we have the epithelium, about 50 microns. Bowman's layer is thicker, but grammatically only represented by a red line here. Then you have all these lamellae crisscrossing one another from limbus to limbus, and this gives the strength of the cornea. And right down to here, this is still part of the stroma. Right down here is approximately 10 microns, between 6.5 to 13.8 microns of Dua's layer. This is of huge importance to DALK surgery. And beyond that, you have decimated membrane carrying a monolayer of endothelium. All right, so where can we dissect and where are the surgical planes? So before the big bubble was discovered, we have always relied on blunt lamellar dissection. So here we are basically using a mostly blunt instrument to separate lamellae, one layer on top of another. Now, there is some point of not going all the way down, but maybe only to about here, when it is very desirable to keep the eye strength, integrity of the globe. For example, in a Down's patient who needs to see, but you also know that they may not be very careful with their eyes, they might rub their eyes, so you keep some residual stroma, and it may compromise the vision quality a little. However, it can keep the eye intact. All right, then we move to basically where the bubble may dissect. Okay, so anterior to duous layer, this is the plane of separation here. This would be the typical type 1 bubble, which doesn't go right to the periphery, but only the central part, okay? And Professor Bahgat will tell you all about this. Now, this is generally desirable due to the physical strength of duous layer. Duous layer immensely tough, so you can blow up the cornea, blow up the globe at very high pressure, and if you just leave duous layer, it will actually, the eye will not pop or explode until a very, very high pressure. There is yet another plane here, which is between duous layer and Descemet's membrane. So here, if this was cleaved by an air bubble, that would be your type 2 bubble, and it gives you a very, very smooth surface, which actually is not desirable, because although you may get a little bit better vision, you are taking a huge risk with the integrity of the globe. Descemet's membrane is thin and can rupture, and when you are dissecting or when you're cutting in the periphery, it can just suddenly pop, and then you would have a job to continue with a DALK, although that is, of course, possible. And again, Mohammed will show you later. So actually, it would be better if you don't go that far down. It is not necessary. It is much better to keep duous layer. So there you are. This is the opening part of the talk, and then you will hear the other speakers. So in terms of suturing, obviously, we need interrupted sutures, and for young patients, they loosen and you have to remove. But what is necessary is to make sure the anterior part of the ocular surface is smooth and flush. Now, you will have different thicknesses. So you may have a thicker cornea than the thinner periphery. So in your keratoconus, even out here, it may be thinned, etc. So what you have to do is to allow the periphery to rise to meet the donor button, which you put on. So what you do is you have to undermine 360 degree so that this periphery can rise. And what you need to suture, this red one being antenno nylon, for example, that you choose a particular depth to exit the donor button so that you can go into this plane and then go up. And so this thickness should be about the same, and you will get a much better front surface. So that's all I have to say, really. And I'm going to pass on the microphone to Ahmed, who is going to tell you the different methods, different techniques. And then afterwards, Mohammed will explain to you all the different bubbles, big, small, type 1, type 2, mixed, micro bubbles. Thank you.
Thank you very much, Professor Lou. Dr. Ahmed, please.
Yes, I'm just sharing screen now. Okay, can you see my slides now?
Yes.
So firstly, I would like to thank Professor Dr. Sinjab and Professor Dr. Liu for inviting me to speak in this distinguished course about DALK. Oh, sorry, just so it's a little bit, we've got some OCD here. Okay, so I'm going to give like an overview about DALK techniques. Some of these DALK techniques have been introduced, have stood the test of time and test of competition. Some have not, some have been withdrawn, and the surgeons now focus on a few of these techniques. So no financial interest to disclose. So as a quick background, so Meles has introduced the manual stromal dissection DALK. That has actually been the technique used by most surgeons for some time until Dr. Anwar introduced the cleavage separation or the big bubble DALK. So about the Meles one, as you can imagine, going manually through the stroma to reach the plane that you would like to do DALK on, that will give you irregular stromal bed, higher risk of interface scarring, interface related astigmatism, higher order aberrations, and there is high rate of perforation because you're relying upon your manual skills to reach the desired plane. Then there was also automated lamellar keratoplasty, where similar to LASIK, you use a microkeratome to cut a certain thickness, a certain depth of the cornea, and use that microkeratome to also cut the donor tissue. So in theory, it may give a smoother interface compared to the manual dissection technique, but still they found that the microkeratome would leave behind micro irregularities that may lead to higher order aberrations as well. And then the cleavage separation, the Anwar's big bubble DALK, and the variance of the big bubble technique, depending on which type of bubble you would get during the injection of air in the stroma. And Muhammad will kindly cover these variations. Recently, there has also been the utilization of femtosecond laser to guide the surgeon and use of anterior segment OCT to assist your DALK technique intraoperatively. Unfortunately, these machines are not available everywhere. So most of us have particular interest in the ones colored in red, the big bubble DALK with the variations of that. So as you just in comparison to the manual dissection DALK and to the microkeratome DALK, because the big bubble, as Professor Liu has explained, would get us to a smooth dual layer plane. So that will improve the optical property of the interface. There's also the ability to expose Decimate's membrane over a wide surface. Unfortunately, that technique doesn't come without disadvantages. So as you all know, it's a steep learning curve. Unfortunately, the outcomes as well are related to the surgeon's experience. So if an experienced surgeon is doing big bubble DALK, the success rate and the outcomes will differ significantly compared to a beginner. There is also risk of anterior chamber entry and perforation, especially in the more difficult cases that has deep corneal scarring and those that have pre-existing perforation like previous high drops in keratoconus cases, for example. I keep getting this question from colleagues who are starting DALK, what instruments, what equipment we should have in hand. So this is just a summary of the instruments that I prefer. Different surgeons have introduced different instruments, and different surgeons have different preference to which instruments to use. So essentially, you need a stable wire speculum because you want good exposure of the ocular surface during the initial steps and also during suturing. There is different air injection cannulas. Fogla has introduced one, Donald Tan has introduced one, Sar Nicola has introduced one. I prefer to use the Tan air injection cannula. And essentially, you can even use a 27 gauge needle mount on a syringe and bend that and use it instead of these ones. Tan DALK scissors, I prefer that, and I'm going to explain why in a minute. And like any keratoplasty, these bottom instruments, needle holder, you may need Vanna scissors, your choice of Trifine, and a pair of a couple of tying forceps. The reason why I prefer this DALK scissors is because, as you can see in the picture, so you've got a base plate, which is like a guard against perforating the decimate membrane, as you can see in the photo. The upper blade is shorter than the lower blade. So when you, like my fingers here, when you try to cut with it, there is with a blunt tip and also the two blades not meeting in one point, there is much less chance of entangling and cutting the decimate's membrane. And of course, most of the dimensions or the sides of this, apart from the cutting side, are blunt. So you get less chance of perforating. Now I'm going to show you a couple of videos of various techniques. That video is actually one from my fellowship, so the early days. During that time, we used to do anterior lamellar keratectomy, remove the superficial hat of the cornea before injecting the bubble. So that was the reason why I like to share this video, because it was during my learning phase. So there's lots of learning points as we go along. So I'm going to show you now, this actually was a 27 gauge cannula mount on an air-filled 5 milliliter syringe. And now I'm injecting the bubble. I used slow motion here just to show you when the big bubble forms. And when you get this big bubble, the one that starts in the center expands towards the periphery with more or less whitish margin around the extremities of it. That is a guide towards a type 1 bubble. So you know that you've got a type 1 bubble with a tough dual layer or predesmatic layer underneath, so less risk of perforation. And then the next step, which is the brave slash, essentially you put some viscoelastic on where you want to cut that superficial cornea, and that to reduce the amount of air coming out and the chances of getting the decimate to hit the blade. Now I want you to see this, so I'm gonna just go backward a little bit. So this actually was in the early phases. We didn't make a side port paracentesis to release the pressure before the injection of the air bubble. So I want you to see while injecting the viscoelastic here, because the bubble is under pressure, the viscoelastic just comes out. So essentially, as you can see, it's all about physical forces here. So if you're trying to inject viscoelastic to dissect that plane, there is posterior pressure from inside, the viscoelastic will just come out, and there is higher chances of hitting the decimate's membrane. While after creating a paracentesis and releasing some of the aqueous to reduce the pressure, now again, this is in slow motion. So you will see the wave of viscoelastic filling this potential space, expanding now inferiorly, is in slow motion, and then now expanding nasally. And now I'm quite reassured that I fill this potential space with viscoelastic. Now using that scissors to debulk the stroma in like divide and conquer manner or fashion. So we cut it into 4, or some surgeons prefer to cut it into 5, depending on what you're comfortable with. This step I would highly recommend starting and beginning surgeons to practice in a wet lab, because in a way, if you achieve a successful big bubble DALK, it's quite unpleasant to get a perforation of decimate's membrane while removing the superficial stroma in this step. So you try different ways, different angles, what you're comfortable with to the right or to the left scissors for each of this quadrant until you reach the technique that you are comfortable with. So I'm gonna skip that. It's similar. I explained to you my preference of the scissors and why this is my preference. There is a bit of ledge around the edges here, so I'm just gonna trim that before going towards the graft. Of course, we've removed the decimate's membrane from the donor graft, and now just 16 interrupted sutures. And finally, just adjusting the pressure in the AC, filling it with aqueous, with BSS, and then subconj. So you wouldn't always get the same outcome. So you may get different types of bubble. Muhammad will talk us through this. This was a more challenging case, now recent one. So we started to make a paracentesis now before injecting the air bubble and injecting some small bubbles in the AC to guide us to the type of bubble. Now I also do the air injection before removing the superficial lamella. And as you saw here, we've got a good size type 1 bubble, but you can also see on this side of the screen a clear, let's just stop here. So this side here, we've got an extension of the bubble. So the force was more than required and ended up causing a mixed type bubble or a type 2 bubble plus the type 1 bubble. So type 2 bubble, if you've got type 1 bubble decent size, you can ignore the type 2 bubble, as Muhammad will explain to us, and carry on with your technique, same as the previous case. This case had previous intracorneal ring segments implanted. So we're going to explant those now as part of the lamellar separation and removal of the stromal lamellae. Again, the brave slash injecting viscoelastic in this potential space, and then the rest of the steps will follow as the previous one. So I focused more on the type 1 big bubble management because I know that Muhammad will talk to us about different types, how to manage type 2, and what if you don't get a decent bubble altogether. Again, removal of the quadrants of the stroma here, and then removal of the decimates from the donor, cutting the required size, and suturing as usual with 16 stitches. And that concludes this surgery. So sometimes you may not get type 1 or type 2 bubble, and after this is the Moria trifine. It's guarded trifine, so you can choose the desired depth to start with and not cross that depth when you keep rotating. So this one, there was no type 1 formed. So just stromal whitening, lots of whitening and smaller bubbles, micro bubbles in the stroma, but no signs of big bubble formation. So I decided to proceed in this with a manual dissection technique, which is essentially choosing one of a decent sized bubble of the stroma and opening the plane of that bubble, and then using manual dissection instruments to reach that plane. Before doing that, I'm trying to inject air in different positions, different locations, just in case I may get a type 1 bubble, or if not, at least I get more stromal microbubbles to use to help me with the rest of the manual dissection technique. Now I'm going through the planes of the stroma using a blunt instrument to dissect, and the target is to reach as far as possible towards dual layer. This case was also complicated by a perforation. As we mentioned earlier, when you do manual dissection, you have higher chances of perforating, but no panic. If the perforation is a small size micro perforation, you can still carry on your dissection. So now you can see aqueous coming out and there is a perforation. As a test, I put air bubble in the anterior chamber to see if the bubble stays in the anterior chamber, that means the perforation size is small, and I may still carry on with my manual dissection and reach the DUA layer or the predesmatic layer. So we carried on here with manual dissection, debulking of the stroma, and you can see the bubble is still in the anterior chamber. After removal of the stroma, I'm going to inject some air again to see the extent of the perforation. It's quite a small perforation around this size. And all what that causes is that it may increase the chances of double anterior chamber, the need for rebubbling after deep anterior lamellar keratoplasty. So you may need to leave a decent sized bubble and in the end, ask your patient to lay flat, and you may also need to come back a week later to do another shot of air injection if there is desmate detachment behind the graft. This is just an example of a case that had a perforation, and you can see here 24 months following the surgery, just a defect in the desmate, but is not significantly causing corneal edema or decompensation or failure of the graft. So just to summarize, these last two slides are what to do and what to not do if you're starting as a DALK surgeon. So do take your time. This is not meant to be a fast surgery. Allocate extra time and be patient. Choose more straightforward cases. Avoid cases which are having significant scarring or previous eye drops if you want to achieve DALK. You choose the correct instruments that suit your technique. Practice your technique through wet lab or go with another surgeon to watch them, and always ask more experienced surgeons for tips if you have a difficult case. Don't attempt difficult cases initially. Don't rush the surgery because it's gonna end up with a failure and conversion to PK if you rush it. I wouldn't use sharp scissors, especially to start with. Also, while injecting the air in the stroma, don't go towards the thinnest part in an advanced keratoconus cornea. Stay away from the thinnest point, and don't inject air with force because this is what induces a type 2 bubble or a burst type 1 bubble. And thank you very much for your attention.
Thank you very much, Dr. Ahmed, for the nice presentation. Now, I'd like to invite Dr. Muhammad Bahgat, please.
Hello, everybody. It's a pleasure to be with you today. And thanks to Professor Mazen and Professor Christopher for inviting me to this session. So now I'm going to go somehow advanced in the field of the big bubble DALK. So can a big bubble be a small bubble or a micro bubble? So I will present first the big bubble technique. So this is a short video showing the classical big bubble. After partial trephination, we inject air in the anterior chamber. There's some whitening and then a circular silvery opacity filling the corneal stroma and displacing the air in the anterior chamber to the periphery. Doing a brave slash, evacuating the air and replacing it with viscoelastic, then removing the stroma, dividing it into quadrants and removing the whole stroma, leaving desmate membrane covered with a thin layer of the stroma, which we call the predesmatic layer or Duas layer. So this is the classic big bubble technique, which make our lives easily and make surgery fast with perfect interface. But usually this doesn't happen in most cases. So the rate of big bubble formation varies in the literature from 50% till 90%. But this rate was in publication done before 2012. At that time, keratoconic cases have no options other than keratoplasty or hard contact lens. Very few people were practicing cross-linking and few people were doing the intracorneal rings. So now most cases of keratoconus are managed by either cross-linking, ICRs, and DALK is reserved only to very advanced cases. In these advanced cases, the rate of big bubble formation is much lower. So now if we are looking for a big bubble, we will only find it in less than 40% of the cases. So we must have a backup technique for as an alternative technique to the big bubble. So what if we don't have a big bubble? So this is examples of cases which we have only corneal whitening, but no big bubble formation. This may be related to some factors, either related to the patient or to the surgeon. To the patient, The filled big bubble may occur in scarred corneas, those with previous hydrops, previous cross-linking, and very thin corneas, or may be related to the surgeon's technique. Superficial trephination, improper introduction of cannula, escape of the air into the anterior chamber through the paracentesis or the trabecular meshwork, or perforation of descemet membrane are all factors which may contribute to the failed big bubble as in the shown videos. So how can we manage a failed big bubble? Although some surgeons may resort to penetrating keratoplasty in cases of failed big bubble, usually I never do this, and I do not recommend doing this because you still may have very good results with other techniques. So if you have a failed big bubble, this is only corneal whitening, no bubble was formed, you may try injection in another site. Now I am trying injection. This is the third or the fourth injection, another fifth injection. And then you may remove the superficial lamellae, do a superficial keratectomy, and try injection at a deeper level. So here we are using a 27 gauge insulin syringe, insulin needle. This is the 6th or the 7th injection. And now the 8th injection, you will find that the big bubble formed, and you can continue your technique. So after 8 injections of air, finally, you may have a big bubble. But still, there is an incident which you may not have a big bubble even after many injections. So you must use alternative technique which you must train on it, such as the hydrodelamination, viscodissection, or the microbubble incision technique. For me, I prefer the microbubble incision technique previously described by Rice et al. And this technique, in short, you can do layer by layer dissection using the crescent knife, and then put a viscoelastic on the stroma to enhance visualization. At this time, you will find many bubbles. You will find bubbles in the anterior chambers, intrastromal bubbles, and small bubbles in the supradescemetic plane. You must choose the deepest microbubble you find, which will guide you to the predescemetic layer or as near as you can to the predescemetic layer. Continue dissection with blunt spatula or dissector and remove the stroma as in classic DALK. If you find still that the stroma underlying the plan of dissection still harbors microbubbles, you can continue the process again. So this is a diagram showing that after injecting air in the stroma, the microbubbles fill the stroma, and usually this is the cause of whitening of the stroma. You can do dissection guided by the microbubbles until you find a very thin layer of the stroma, and at this time you can choose one of the microbubbles that may guide you to the predescemetic layer or Duas layer. So this is example of the microbubble incision technique. So after removal of 2 layers of the stroma, I am now looking for a good microbubble that will guide me to the plan. So this is a microbubble, this is another one. So many microbubbles. I choose this microbubble, open the microbubble using a bevel down insulin syringe. Introduced my spatula. This spatula should be rigid, thin, and blunt. So this is the criteria of a good spatula that will aid in the manual dissection technique. And then I'm removing the stroma. After removing the stroma, I inspected the bed and found that still there is microbubbles present. So this is indicating that still a significant layer of the stroma is present. So this necessitating the repeating of the process until you reach a plane where the residual part of the stroma is devoid of microbubbles. And this is the end plane where then you can put your graft. So how to know you are in the right plane? First, you will find the resistance is less during this section. So as you go deep in the stroma, you will find less resistance during this section. Less tendency to buttonholing, so the dissection is easier, and you can maintain the plane you are dissecting in. After removing of the stroma, you will find no microbubbles in the remaining plate. But remember that if you find your spatula or dissector going into the plane with no resistance, then expect you are in the plane between the descemet membrane and the predesmatic layer. And this is very dangerous because descemet membrane is fragile and it will rupture easily. So avoid, if you find no resistance, then you withdraw the spatula and try to find another plane where you find some resistance, indicating that you are in the proper plane. So these are examples of pictures showing the microbubbles, but this is the small bubbles which will guide you, and these are the bubbles in the anterior chamber. So to make visualization easier and to make identification of the microbubble easier, so either you may have to evacuate the bubbles in the anterior chamber, or you may replace it by a big bubble which will enhance the visualization. So remember that if you find a bubble like this in this side, this bubble probably it is a small type 2 bubble, and you should avoid, because this is usually in a very wide plane, which is between the predesmatic layer and descemet membrane. So this is how to manage the failed big bubble using the microbubble technique. So now I will describe the variance of the bubbles, the variance of type 1 bubble and the variance of type 2 bubble. Unfortunately, the time will not allow me to discuss the mixed bubbles. So we will discuss type 1 and type 2 and their variance. So type 1 is an intrastromal bubble between the predesmatic layer and the stroma. So here we will find that there is the start of the formation of the type 1 bubble starts in the center and goes till the trifinition edge, and the margins is wide margin bubble. So it extends, it's less than 9 millimeter and usually covered by the tough predesmatic layer. Here's a type 2 bubble. It always starts in the center in keratoconus, but maybe starts in the periphery in other pathologies. It has a clear margin and usually extends beyond the trifinition groove and may reach up to the limbus. And as Professor Leo said, it is between the descemet membrane and the stroma. So if you manage this bubble, you open the bubble, you will find a bare descemet membrane. So a type 1 bubble is not essentially to be a big bubble. It may be a small bubble if there is adhesions or scarring between the predesmatic layer and the stroma. Also, a type 1 bubble may be a collapsing bubble. So if you just withdraw the cannula, you will find that air will escape from the track of the cannula or from a descemet membrane tear. If you increase the force of injection, the type 1 bubble may burst, or it sometimes bursts if there is tight adhesion between the stroma and the predesmatic layer, or there is weak point in the posterior wall of the bubble. So this is a small bubble, an incomplete big bubble. So I am injecting now, and I find resistance to the increase in the size of the bubble. So if you find that a small bubble is formed and do not increase the force of injection, do not try to increase the size of the bubble. The bubble did its job, which opened the plane between the predesmatic layer and the stroma, which is our target plane, and you can continue the section of the remaining part manually. And I'm stressing on do not try to increase the force of injection and to increase the size of the bubble. So this is a collapsing bubble. You inject air and you find that a big bubble is formed, and you find the air in the AC is displaced to the periphery, and after you draw the cannula, the air will return back to the center, indicating that the bubble collapsed. This collapse may either due to escape of air from the track of cannula or perforation of descemet membrane. So what to do in such case? You may inject viscoelastic in the same track instead of injecting air. Air will evacuate from the track of the cannula, but viscoelastic will remain forming the bubble. So that's what happened, what I did. So I am now doing dissection, removing the superficial lamellae and injecting then viscoelastic, which will form the bubble and will maintain the bubble form. Then removal of the whole stroma, and we will find here the site, the cause of the collapse of the bubble, which there is a small perforation in this area, which made the bubble collapse. So first, big bubble. So here is the case of post-microbial keratitis scar. I'm performing DALK, injecting air in the anterior chamber, having a very nicely formed big bubble, feeling that life will be easier and surgery will end in a good time. Then the bubble burst and air is filling the anterior chamber. Of course, this is the scarring may be a deep scar. There may be a weak point in the posterior surface of the cornea, and here I am pointing on the perforation. In such case, do not convert to penetrating keratoplasty. Start dissection from the periphery and leave the central area, helping the perforation to be the last part. So this is how to manage a case of burst big bubble. So this video may be more illustrative than the other one. I'm injecting air, didn't have a bubble, but just have a bubble in the anterior chamber. Doing DALK, removing the superficial lamellae, using the microbubble incision technique. But in such case, I'm using the microbubble incision technique in the periphery only, doing circumferential dissection in the periphery, leaving the central area to be the last part to be removed. I'm still here, didn't reach the desired plan. Still there is much microbubbles, trying to reach a plan devoid of microbubbles. And now I'm feeling that I reach a good plan. Try to peel the center. I know now that there is a perforation and I'm expecting the perforation, doing peeling carefully from all directions. And when I find the perforation, do not panic. Although there is some collapse of the anterior chamber, continue the peeling from other sides so that not to extend the tear. And you'll find that this was caused only by a small tear, and the bubbles in the anterior chamber can be kept, and you can continue DALK safely. So now I'm going to talk about type 2 bubble, which is similar to type 1 bubble. It may be a complete type 2 bubble, an incomplete type 2 bubble, a collapsing or a burst type 2 bubble. So this is an incomplete type 2 bubble, a small type 2 bubble, a case of keratoconus, and you will find that type 2 bubble is starting in the center also, not in the periphery, and extending till I stop the injection when I realize that I'm having a type 2 bubble, which is not a desirable bubble. So this is a collapsing type 2 bubble. I'm having a complete large type 2 bubble. The bubbles in the anterior chamber displaced to the periphery with a clear margin and the bubble extending to the limbus. When I remove the cannula, it collapsed. Inject it again, remove the cannula, it will collapse. Now I'm trying to do whitening of the cornea, and I'm having finally a small type 2 bubble. The first type 2 bubble is not similar to type 1 bubble because a type 2 bubble usually forms in fractions of seconds. It's very fast and you may not realize that it is a burst type 2 bubble. Here's a case of macular dystrophy. I didn't realize what's happening, but after removing 1 or 2 layers, I found that the descemet membrane is crumpled into one side after the air filling the anterior chamber. So now I'm trying to dissect the remaining stroma. I know that there is a perforation here, but when I introduced the scissor, I had a burst bubble again. So I'm having now 2 perforation, and descemet membrane is, as you can see, there is a large perforation here and another perforation in this area. So this is the burst type 2 bubble. So how to manage a type 2 bubble? Remember that our aim is to reach the clear predesmetic layer and not to bare descemet membrane. We can start by removing 1 or 2 layers of the stroma and use the stromal microbubbles as a guide. We can dissect as deep as possible, then either keep a clear predesmetic layer or remove the central 4 millimeter bearing descemet membrane only centrally. After that, you can do a small puncture in the predesmetic layer to collapse the bubble and allow descemet membrane to re-adhere to the stroma. Suture the graft and then partial AC airfill. So you should remember that a type 2 bubble is associated with high risk of formation of double anterior chamber, even if you are having intact descemet membrane. So this will necessitate a strict supine position after a type 2 bubble. A short video showing how to manage a type 2 bubble. So after doing 1 or 2 layers, removing 1 or 2 layers, I'm using the stromal microbubbles to reach the predesmetic layer. Now I'm having a type 2 bubble. These are bubbles in the anterior chamber displaced to the periphery, and the type 2 bubble is covered by the predesmetic layer and maybe a part of the stroma. I shouldn't leave the bubble like this, so I should collapse. Although I reached a good plan and a good depth of the stroma, but I should collapse this bubble by doing a puncture in the predesmetic layer. And this is the residual type 2 bubble, and the bubbles in the anterior chamber will go to the center. Another case of a type 2 bubble. This is a case of post-chemical burn and stem cell transplantation. Injecting air, you will find that a type 2 bubble is formed with the bubbles in the anterior chamber displaced in the periphery, and the formed bubble reached till the limbus. So I'm doing the keratectomy, removing 1 or 2 layers of the stroma, using the stromal microbubbles, opening on 1 of the microbubbles, doing manual dissection using the viscoelastic cannula, and removing the stroma, reaching a plane without microbubbles. And now I'm going, this is a type 2 bubble covered by the predesmetic layer. Now I'm going to collapse this bubble because it is a complete and filling the anterior chamber. And now the bubbles in the anterior chamber will go to the center. So my take-home message is after air injection, you may have either a big bubble, a failed big bubble, or big bubble variance. Type 1 is the preferred bubble after pneumodissection. Type 2 bubble is a surgical challenge and should be managed with one of the manual dissection techniques. The small bubble can be completed manually without trying to enlarge the bubble. The microbubble incision technique is one of the useful manual dissection technique which usually guides to the predesmatic layer. And remember that the big bubble usually makes life of a corneal surgeon easier, and this is my preferred bubble to live in. So thank you.
Thank you very much,
Yes.
Professor Bahgat. Great presentations. Thank you very much. So, Professor Liu.
I must say, I've seen that big bubble before behind Professor, and did you know it's air conditioned? And it's actually a hotel. It's a hotel room in Switzerland.
Yes.
All right. Well, I think everything has been very, very clear. And Professor Bahgat summarized the situation very well, saying what is desirable, what is not desirable, and how to rescue situations using the micro bubble technique as manual dissection. So has any questions come through in the chat box at all? I don't see any questions. I think maybe for once, DALK is clear. It's a clear bubble.
Type 2 bubble.
Oh, yes. And Professor Sinjab, do you have any questions for the speakers or for me?
Everything was clear. Thank you very much. So it was very simple and direct to the point. So maybe there will be some questions from the audience regarding some surgical tips or some maybe difficulties that they face during doing this technique.
Okay, so there is one question from Mustafa Saba, and that should be answered by Professor Mohammed. What are the variants of mixed bubble?
The mixed bubble, you are having type 1 and the type 2 bubbles. You may have a complete type 1 and a small type 2, or a complete type 2 and a small type 1, or you may have a small type 1 and type 2. Both are small, or the very rare event of having both complete bubbles. So may have a large type 1 and a large type 2, which is a very rare event. So there are 4 variants depending on which is small and which is big.
Let me ask a question to Professor Mohammed. You know, if people get very frightened of bubbles, are you okay for people not to do bubbles, but really just to make the stroma opaque by one way or the other, and then dissect manually down to the appropriate level? Are you okay with that, or do you think that is considered a failure?
I don't recommend this because still you have a 40% chance of having a big bubble technique, which may make life easier. And still you have the option, if you didn't have the big bubble, you may use any other techniques which may cause whitening. So you may combine the pneumodissection with hydrodelamination, or you may combine the pneumodissection with the viscodissection. So if you are not comfortable with the bubbles and you could not manage them, just give a trial for the big bubble, and then you can resort to any technique of your preference. But the big bubble really makes life easier.
Okay, so try it first, and
Yes.
hopefully you get a type 1, and then if you get a type 2, then deal with it. Yeah?
Yes.
Great. Another question for you from the same person, Mustafa Sabah. Is older age a risk factor for formation of a type 2 bubble?
Yes, a type 2 bubble, usually the certain published risk factors for the formation of a type 2 bubble. Old age is one of these risk factors. Advanced form of the stromal disease is another risk factor. Macular dystrophy is a risk factor. Deep stromal scars also is a risk factor for type 2 bubble. So if you have also an advanced keratoconus, you may have a type 2 bubble. So any disease which may cause destruction of the predesmatic layer and allow air to pass to the peridesmate membrane may lead to type 2 bubble. So old age, there is some controversy in previous publication. 2 publications said that it is a risk factor, and 1 publication said it is not a risk factor. So there is some controversy, but actually you may not know if this is because of old age is associated with advanced form of the disease, or because of there is some structural changes in the predesmatic layer with old age. But actually, in my observation, old age is a risk factor.
Thank you. Now there's another question in the Q&A, but I don't fully understand the question. It says in the collapsed big bubble, is there an examination to be done before maybe trying to get another bubble, just to find out if there's a perforation in Descemet's membrane?
If you are having a collapsed big bubble, there are 2 situations which may lead to this. Either the air will escape from the track of the cannula or escape from Descemet membrane in itself. In the case I presented, when I removed the superficial lamellae or did superficial keratectomy, I found that there is escape of aqueous. So this may be a sign that there is a perforation on Descemet membrane. So I think it will be obvious that there is a perforation of Descemet membrane, or you sometimes may even see the perforation itself if there is not much whitening of the stroma.
Thank you. And Ahmed, how did you come to choose the cannula that you prefer? Have you tried everything? And can you just remind us how the tips are different and how the bore are different, giving rise to different pressure?
So I tried the 27 gauge needle. The good thing about it is that you don't have to create an entry point for it. You can try to dissect with the tip of the 27 gauge needle. But the problem with it is that it's quite sharp edge. So if you are deep in the stroma, it's higher chance of perforating. Fogla cannula and TAN cannula. Fogla is advantageous in being quite blunt, and the opening is on the under surface of the cannula. So that also gives you like the freedom to move through the layers with a blunt end without the worry of perforating. TAN is, I think both are quite good. So it's the good thing about the TAN cannula is that it combines both in my view. So I see that it's also it's blunt, but not very blunt. So it can help you, the tapering end of it can help advance the needle within the stroma compared to the Fogla cannula. Mohammed, do you have any preference to which one to use?
Look, I tried the San Nicola, I tried the Fogla cannula. I find they are all similar. They have the advantage that they are blunt cannula, so introducing it in the stroma, you will feel you are safe if you are going to go deep in the stroma. The problem with these cannulas that usually they are blocked easily, so you may have to buy one every couple of months. So in the era of the corona, I had my cannula blocked and I couldn't buy another cannula, so I stopped using this blunt cannula and resorted to the insulin syringe. I'm good with the insulin needle, but still I feel that using these cannulas is much more safer.
Yeah, we're not allowed to reuse them here anyway, so we get a fresh one for every case, which is
Really?
luxury.
Really?
Yeah, they have
But they are disposable.
the disposable ones. Yeah.
Oh, so I have a disposable one. Good. We don't have this luxury in Egypt.
Okay, well, thank you, both of you, and thank you, Professor Sinjab. I think we have explored this, the surgical planes and bubbles quite adequately now. So I'll hand back the microphone to you.
Thank you very much, Professor Lu, and thanks to Professor Ahmed Bahgat, Mr. Ahmed Shalabi for the nice presentations and the coverage of this topic. Really, it was very interesting time and very nice session. Thank you all and have a good night.
Thank you.
Bye. Thank you. Bye-bye.
Here in Dubai, have a good night. Still in the UK, have a good evening and enjoy.
Thank you.
Thank you.
Bye.
Bye.